Good afternoon and welcome to today's MAHSC seminar. I'm Peter Traynor, the Clinical Director of the Manchester Academic Health Science Centre. My first duty is just to set a few of the house rules. For those following on Zoom, please keep your microphones and cameras switched off until we take questions at the end. We're going to have two presentations of approximately 20 minutes to leave a further 20 minutes for your questions and general discussion. If you're listening on Zoom, you can use the chat facility to ask your questions. But if you're watching on YouTube, can you send your questions by email to MAHSC Seminars all one word, healthinnovationmanchester.com. That's MAHSC Seminars healthinnovationmanchester.com. And also you can use that email address to send us future suggestions about seminars and topics and potential speakers. The next seminar after today will be in 2 weeks' time and is going to return to the theme of COVID, and in particular look at the very important impact of COVID on the Black, Asian, minority, ethnic groups, the explanation, and look for possible means of addressing the sad excess of mortality. We'll soon be returning to the subject of COVID, but today the theme is the prevention and early detection of cancer as a means of transforming outcomes. And even in times of COVID, this remains extremely important. A lot of people will be aware that there is a concern that the redirection of all the NHS's efforts into dealing with COVID means that cancer diagnoses are going to be delayed, that we're going to see a rise in cancer mortality because of delays in treatment in a year or two, but in 5, 10 and 15 years, we may also see excess mortality because of the missed screening opportunities, the failure to detect and prevent earlier. Cancer is one of the 5 themes of the Manchester Academic Health Science Centre. And approximately 8 years ago, Sir Salvador Moncado was recruited to lead the university's efforts on cancer. And initially there was some controversy because his background was not in cancer research. He was just a very distinguished scientist. But he had a transformational effect on cancer research in Manchester because he challenged the system, making the point that all the work we were doing around new treatments, be they medicine-based, be they radiotherapy-based, would never have the same impact as prevention and early detection. And he drove a transformational change in the thinking in Manchester to focus on prevention and early detection. And that's gradually come to pay in various ways. The most telling being that exactly 1 year ago today, on the 21st of October 2019, Manchester was able to announce that it had been selected by Cancer Research UK to join Stanford, MD Anderson, Cambridge and Oregon as the recipients of awards totaling £55 million to address the topics of prevention and early detection. And in Manchester, we'll be looking at various cancers, the impact of screening, as well as biological models to look at the changes in, for instance, healthy breast tissue through to the development of cancer and how where targets not for treatment, but prevention and early detection can be identified. And we're very fortunate in Manchester that we have some very distinguished speakers on this topic, and we're going to hear from 2 of them today. First of all, I want to introduce Gareth Evans, Professor of Medical Genetics and Cancer Epidemiology at the University of Manchester, an internationally recognized key opinion leader working on the genetics of cancer. He's got in excess of 800 publications. For those of an academic bent, his H index is 106. His Google Scholar Index is 144. Stellar. In the last 2 or 3 years, he's raised approximately 31 million in cancer research funding for Manchester, the largest proportion being as the NIHR BRC theme lead for cancer research. He's also the director of the program of research, which I described for a moment ago under CRUK. And he's going to talk to us about risk stratification in cancer for approximately 20 minutes. And when he's finished, we're going to hear from Emma Crosby, recently appointed professor of gynecology oncology at the University of Manchester. Emma was fortunate enough to study medicine in Edinburgh, where she got a first-class degree along the way at BSc in psychology before graduating MB-CHB honours from Edinburgh, something they give out very rarely. She's collected a myriad of prizes since then: the Drever Prize, the James Scott, the Dorothy Gilfin, the Harold Malkin, the William Blair Bell, all of which unsurprisingly means it was Manchester's fortune that she moved south from Edinburgh, did her PhD here, worked in the Patterson Institute, and is going to talk to us about her ongoing studies on endometrial cancer risk. So with that introduction, I'm going to switch off my microphone, switch off my camera, and pass it over to Professor Evans. Gareth.
Hi, thank you, Peter. I'm just going to try and find somewhere, if I can find it, my presentation. Here we go. As Peter said, I'm going to talk for around 20 minutes, and I'm going to concentrate on risk stratification or risk assessment in cancer. And for that, breast cancer really is the leading light in terms of how we have been able to much more accurately assess risk, and that women are not at just a 1 in 10 or a 1 in 8 lifetime risk of breast cancer that is the averaged risk across the population. But in reality, many women, most women are actually at less risk than that. But a few women can be at extremely high risk, and I'm sure all of you have heard of BRCA1 and BRCA2, and if you have faults in those, your risks can be into the 80% in your lifetime. One of the things I'm going to use as a vehicle to explain to you how much better we can assess risk is a study called Predicting the Risk of Cancer at Screening Study, PROCAS, which started in 2009. We now have more than 10 years follow-up on many of these women, and we recruited 58,000, including 10,000 that we collected saliva DNA. So there's really two ways of assessing risk for breast cancer. The main one, and the one I'm going to concentrate on, is the risk of breast cancer over time. So that for us tends to be 10 years, but particularly in the family history clinics, when we're talking about younger women, we talk about lifetime risk. So the risk to age 80 or 85, dependent upon which one you choose, as the way of determining what a woman might decide to do. And for instance, a risk above 50-50, which many of the high-risk genes will confer, often many of those women choose risk-reducing surgery as their option of dealing with their risk. And obviously, that brings in the other element, which is how likely is a woman who's not yet got breast cancer to carry a fault in one of those genes. And there are programs that allow us to make an assessment of that. And currently, the threshold for testing in the UK on the NHS is a 10% likelihood of having BRCA1 or BRCA2, which is quite high in order for someone who hasn't got breast cancer to achieve. So how important is family history and genetics? Well, we know that about 4 to 5% of breast cancer, based on epidemiological studies and looking at segregation in families, is likely to be due to single high-risk genes. We actually know that BRCA1 and 2 really only cause about 2% of all breast cancers. And the reason for that is we're flooded now with breast cancers at older ages, and the fact that risk is going up in the general population. So probably if we were talking about 50 years ago, BRCA1 and 2 might have actually caused about 4% of breast cancer. And of course, these studies were actually done in the 70s and 80s when there was a far lower lifetime risk of getting breast cancer. Only about 15% of women who get breast cancer have a close relative with breast cancer, what we would call familial breast cancer. Many of those are not caused by genes, they're just bad luck, but many of them are contributed to. And if you look at twin studies, that is whether identical twins or non-identical twins both get breast cancer, it suggests that around 27% of breast cancer has a strong inherited component. We now know, though, because of the number of genetic variants that have been identified, that essentially every woman's risk will be altered in some way by what they inherit. Most of that will be down to common genetic variants that are carried by many of these common variants have an allele frequency of 40%, which means that over 50% of women will actually carry them. These can be protective, and these may even work the other way. So when we look at a sort of pie chart of the contribution of different elements, hereditary factors probably give a substantial contribution to around 27% of breast cancer. Lifestyle factors a bit over a third, lifestyle and environment, and then the rest is largely down to chance alone. And so chance does play a part, but if your risks are extremely low, you would be extremely unlucky if you develop your breast cancer by chance alone. So what about the other genetic factors other than high, moderate risk genes and these common variants? Well, mammographic density is by far the most important of those. And that is something we can easily measure now when women go for mammograms. Essentially, we're looking at the fibroglandular tissue. So the more there is of that, the more dense the breasts are, the more it shows up white on a mammogram. And we can't entirely say that that's not genetic, because actually the evidence is that has a 60% inherited component to it, although we're far forward in identifying what those inherited factors are. There are many other factors, many of the factors we use in risk models, like when periods start and stop, late first pregnancy or early first pregnancy. You'll be pleased to see alcohol is fairly low on that list, but is one of the few things you can actually do something about. So we use models, and the two models that we really tend to use nowadays are the Tyrer-Cuzick model, which we use largely in our family history clinics and in the general population, and then the Boadicea-Canrisk, a model developed by Cambridge that actually looks at primarily originally to identify faults in the BRCA genes, but is now able to give a risk over time of developing breast cancer, taking into account other factors. So what are the actionable elements? So why bother to calculate risk if it's just to frighten people or not, as the case may be? So NICE, since 2004, have gone along with the whole idea of triaging breast cancer risk into three categories: high risk, which is a lifetime risk above 3 in 10, or an 8% risk in the next 10 years. And those women, for instance, get offered annual mammography between 40 and 60, and we can also offer them preventive medicine in the form of tamoxifen if they're premenopausal, or anastrozole if they're postmenopausal. And 5 years on each of those drugs reduces the risk of breast cancer, as far as we can tell, for at least 20 years, maybe for life, and that's 40% for tamoxifen and 50% reduction for anastrozole. Moderate risk is 17 to 29%, or a 3% 10-year risk at the age of 40. And they largely only get a little bit of extra screening before the national program at 50, between 40 and 49. And we can also, fact, that should say consider chemoprevention, and many of those women do actually take up that offer. So this is just showing you the risk model that we largely use, which is Tyra Cusick, developed by Jack Cusick at QMUL. We put in the age, when they started their periods, the height actually is a risk factor, and you can see here density, and that's a really important factor. So in this woman who's actually not had children and has dense breasts, actually a lot of her risk is not down to her family history, which is relatively mild. And you can see here, she ends up at the age of 40 with a moderate risk, even though she doesn't meet the NICE criteria for moderate risk from a family history point of view, and a lifetime risk of around 1 chance in 4. So breast density, as I've mentioned, is a very strong risk factor. It changes with age, menopausal status, and with weight, because obviously the more overweight you are, the more fat there is in the breast, which ironically reduces the overall density, but actually women who are obese after the menopause increase their risk of breast cancer. So if you were to take these two women at the age of 40, the one on your right is virtually black. There's hardly any glandular tissue there. She would only have a 4% lifetime risk, whereas this woman on the left with a hugely dense breast, virtually completely white, would have a 25% lifetime risk without taking into account any other factors. So the other thing that's really taken us forward in terms of our ability, other than measuring density, is measuring genetic factors, because family history, as I've already said, is quite a blunt. It only helps in a small proportion, but identifying these common genetic variants, and this is how common they are: 34% of chromosomes up to 46% of chromosomes. And remember, you have 2 chromosomes carry one of these changes, and they can significantly increase or decrease the risk. So if you get the right combination of these, they can really push your risk down. If you get the wrong combination, push your risk up. And you can see here that now SNPs account for more of the inherited component of breast cancer than all of the moderate and high risk genes put together. And they are predicted to account for most of the undiscovered component of breast cancer. So how do we use these SNPs? Well, we essentially normalize their risk around 1, and because obviously those who have favorable SNPs are below a relative risk of 1, and then we multiply them together in what's called a polygenic risk score. And we can get risks of as high as 4 times normal or a quarter of normal, although most women are within a sort of 2-fold relative risk either way. And using these polygenic risk scores, you can see here on the left, women without a family history. These are lifetime risks here by age, so cumulative risks that actually are just on SNPs alone. 20% of those without a family history actually are at moderate risk of breast cancer with a lifetime risk of 17%. But 20% at the bottom end have only a 5%. That's a 1 in 20 risk of breast cancer. And that lower portion actually never reach the average risk at which screening is incepted at 50, which is about a 2.5% 10-year risk. And it works equally well with those with a family history, predicting extremely well, very well separated quintiles. So we've used these principles in our PROCAST study, using the standard risk factors in a questionnaire, using DNA from saliva that we collected, and using density. And what this allows us to do is really stretch out the risks that we see. These are 10-year risks. And remember, these 2 categories here are the actionable risks where we can offer something, either more screening, chemoprevention, lifestyle advice about how to reduce their risk. And this again is the study. We now have 640 prospective breast cancers in the DNA arm, 1,750 altogether. And we've now genotyped with 143 SNPs. We're currently filling the gaps with 313 SNPs, which are the full number now. And we've looked at all the different models. And again, Tyrer-Cuzick comes out as the better model. So this is roughly where we are now. This is the 9,000 women that have that we were able to study with SNPs. And this is using SNP 143. You can see in the blue here that more than half of women are actually, with just the Tyrer-Cuzick model, are in the average risk category, 2 to 3.5%. But when we add in the SNPs and the density, we push a massive proportion of women, well, actually close to 40% of women are now pushed down to below average risk. So a risk below 2% in the next 10 years. And these are all screening age women. But importantly, we now identify about 20% in the moderate and high risk categories, whereas family history alone would only give us 3%. And not only that, we are able to identify 45% of the high stage cancers in that group of women. We could reduce those stages by doing more frequent screening, and by giving a anastrozole to a predominantly postmenopausal population, we could actually halve the number of breast cancers that occur, obviously, if women choose to take that medicine. But the important thing is here that we can rob Peter to pay Paul to some extent, because we know that cash is short, particularly after COVID, that doing a bit less screening in this group will pay for screening in this group, because this nearly 20% of the population only develops 7% of the breast cancers. This just shows you the amount that we stretch the risk out by including these other risk factors, the TCA plus, if you like. And this shows what happens in normality, that women are offered no risk information in the general population. Everyone is treated the same, and we get the same result. Everyone is average risk. Everyone has an average risk. This just shows you, this was based on SNP 18 prospectively, really accurate that we identify women prospectively in these risk categories. So this isn't just us saying, well, this is what it looks like. This is what it actually is going forward. And this just shows you how accurate the SNPs are in terms of their calibration and discrimination, that they're accurate both at the top end. If it's saying a twofold relative risk, it's jolly close to a twofold relative risk. If it's at a half, it's very close to a half. And importantly, identifying low risk women, these women are also at more risk of their proportion that they get of low risk cancers. So this is the sort of overdiagnosis. So actually we would get rid of a lot of overdiagnosis by doing less screening in that low risk population, which, as I've shown you, could be as high as 40% of all women. And as we add in more and do more and more SNPs, we identify more and more women who are in this control population, but we get even better at identifying them at lower risk. So it improves all the time, despite the fact that we're actually putting more information into it. This is at the top end. You can see here 20% we can now identify at moderate and high risk, and that we increase the odds ratio compared to normal in those women the more we add in. We are able to substantially change risk. So 33% move a nice actionable risk group by adding in genetic factors compared to Tyrer-Cuzick alone. And that is an actionable category, either to the very low risk or the high risk. And that adding in a breast panel, it pushes us up to about 40% if we include BRCA1 and 2. However, only about 1.5% of the population carry a moderate or high risk gene. and therefore SNPs make far more difference to the overall prediction, and only around 1% were actually moved a category because about a third of those women were already high risk. So if we look at, for instance, genetic factors alone, 70% of women are affected by their genes in a meaningful way. Around 45% are actually at significantly reduced risk, less than a 0.8-fold relative risk, and about 26% are increased by a significant amount, by at least a 25% increase. So how does this apply to other cancers? Well, this is just to show you that across many studies that SNP 313 works extremely well. This is across all of these different studies, prospective studies, extremely accurate. All the box plots here in the forest looking really very similar. And we can do this in other cancers that are ripe for screening. Actually, if we did good risk stratification, PSA would work in prostate cancer. The problem is we don't do that, and men at low risk have prostate screening. But we can do it in ovarian, colorectal, lung, and actually Emma is going to talk about endometrial cancer, the lining of the womb. So we already do risk stratification. We don't screen men or young women for breast cancer. We don't screen 25-year-old smokers for lung cancer, and we don't screen 65 never smokers for lung cancer. We use risk stratification already. Let's just do it better by including genetics and other risk factors in that. At the moment, by and large, all we use is age and gender in terms of who gets into a screening program. Let's do it better and include genetics. In Manchester at the moment, we have three PhD students working on the SNPs, one with Emma in endometrial cancer, another with Emma in ovarian, and with Emma's husband, Phil Crosby, on lung cancer, because we want to know whether we can even stratify those beyond smoking state and colorectal. So what I hope I've been able to show you is that breast cancer risk stratification is already ready. We should perhaps be doing it even younger, maybe at 40 years of age, and we have plans to do that with Sasha Howell. That SNPs are far more useful than extended gene panels. So really, this is something we should be rolling out, and there are plans to do that. And it's time to make prevention and early detection more intelligent. The studies will be better powered if you risk stratify, so you get more potential cancers that are prevented. And risk stratification will provide that power in all future research. But also, we should be already doing this, and there are moves to think about this in the general screening population. We have PROCAST2 at the moment, BC Predict, which is already doing this on an NIHR grant in Greater Manchester. Thank you very much. And this is the PROCAST team. And I'd like to thank a huge number of people, particularly Tony Howell, who I think is listening. I heard his voice earlier, who with me was really involved in the inception of the PROCAST study, which I think has given us such rich vein, but also people at QMUL, the wonderful radiologists who've looked at so many images. Thank you very much.
And then we'll move swiftly on to Emma.
Thank you. I'm just trying to share my screen. So it's saying one participant can share at a time.
I've stopped sharing, so it's not me.
Okay. Aha. Great. Okay, well, thank you very much. I'm going to now talk about preventing endometrial cancer and the progress that we've been making in Manchester and some of the significant challenges that remain. So endometrial cancer is the fourth most common cancer affecting women in the UK, and its incidence is rising. In fact, the incidence has gone up by 54% over the past 20 years. And as a consequence of this, more women are now dying from endometrial cancer than they did at the turn of the century. And this is due to a whole range of different reasons, including the aging population, the fact that we're doing fewer hysterectomies for benign gynecological diseases. But perhaps the most interesting, because it's the most potentially modifiable, is the obesity epidemic. Endometrial cancer ranks highest amongst all cancers in its association with obesity. We carried out a systematic review with meta-analysis of all the prospective studies of BMI and incident endometrial cancer, and found that every single study, irrespective of the population studied, whether it be North American, European, Australian, Asia Pacific, and so on, every single study found an association between endometrial cancer and obesity. Indeed, the risk of endometrial cancer is 60% higher for every 5 kilogram per meter squared increase in BMI. And this means that at a BMI of 42, a woman has a near 10-fold increased risk of endometrial cancer compared with her normal weight counterparts. This means that the lifetime risk of endometrial cancer in a woman with a BMI of more than 40 is in the region of around 10 to 15%. And to put that into some sort of context, it's not that dissimilar from the risk of lung cancer in a lifelong smoker, which is defined as a woman who smokes more than 5 cigarettes per day. In fact, we now think that around 35% of all endometrial cancers are directly attributable to obesity. And this is important, of course, because the nation is putting on weight. So in contrast to the prevalence of smoking amongst women, which decreased from 27% to 19% between 1993 and 2012, over the same time period, the prevalence of obesity has risen from 15% to 25%. And currently 25% of all women are obese and 2.5% have a BMI of greater than 40. The prevalence of obesity increases with age, so women in the perimenopausal and postmenopausal age groups have an even higher rate of obesity, and rates are linked with areas of socioeconomic deprivation. So they're very high in places like the northwest of England. And I think we're only just starting to appreciate this toxic combination of fewer hysterectomies for benign gynecological disease and the obesity epidemic. And it has been predicted that the rates of endometrial cancer will rise 3% year on year in the United States, until by the year 2030, endometrial cancer will surpass lung and colorectal cancer as top causes of cancer amongst women. So I've painted a rather bleak picture, but is there anything that we can do about this? Well, I think if we can understand the mechanism that underpins the link between obesity and endometrial cancer, then we can use that knowledge to develop novel prevention and treatment strategies. But of course, prevention studies are extremely challenging. So in a cancer treatment trial, we need to recruit and randomize hundreds of women to drug A or drug B and follow them up for several years to see how many recur and unfortunately die from their cancer to show which drug is superior. But for a prevention trial, we would need many thousands of women followed up for many, many years if prevention of endometrial cancer was the primary endpoint. Now, this is clearly wasteful, expensive, inefficient, and you could argue even unethical if there are insufficient robust data to support the use of the intervention. And we clearly need surrogate endpoints to improve the efficiency and cost effectiveness of our research. So, understanding of the biological mechanism that underpins endometrial cancer development can help us to identify precursor lesions that can serve as a proxy for cancer to show proof of principle that any given intervention is likely to work. In other words, to justify a trial with clinical endpoints. So atypical hyperplasia is a really good example of this, because around 25 to 50% of atypical hyperplasias will progress to endometrial cancer if they're left untreated. But there may be molecular changes that precede morphological changes that take place as a endometrium transitions from low risk to high risk of endometrial cancer. And Ki67 could be a really good example of that. So Ki67 is a nuclear protein that is only expressed by cells that are dividing and proliferating. We know that there is an increased expression of Ki67 in endometrial cancer compared with benign postmenopausal endometrium, which is fairly dormant and not really doing very much. And indeed, high Ki67 expression is associated with poor prognosis from endometrial cancer. So Ki67 is the biomarker that we have been developing to act as a surrogate endpoint for our intervention studies. So how does obesity cause endometrial cancer? Well, obesity is a toxic pro-inflammatory state of estrogen and insulin excess, both of which act on the endometrium to cause it to proliferate. And as we said, we can measure this by looking for Ki67. So the hypothesis underpinning our work is that interventions that reduce or antagonize endogenous estrogen and or improve insulin resistance will reduce endometrial cancer risk and or slow tumour growth. And in Manchester, we've been looking at 3 interventions that may offer hope for endometrial cancer prevention. The first is the Mirena coil, which is a progestogen-laden intrauterine device that antagonizes the effect of estrogen within the uterus. Weight loss, which of course reduces the aromatization of androgens to estrogen and improves insulin resistance. And metformin, an insulin sensitizing drug long used in the treatment of type 2 diabetes, which also has weak mTOR inhibiting qualities, which is one of the cancer pathways that we think is important in endometrial cancer. And so I'm going to tell you about some of the progress that we have made looking at these 3 interventions here in Manchester. The first study I'd like to tell you about is the OWL study. So we know that weight loss reduces endometrial cancer risk, but we also know that particularly at very high BMIs, that weight loss is difficult to achieve and sustain by diet and exercise. However, we do know that bariatric surgery does work, and by that I mean gastric bypass or gastric sleeve surgery. Now, obviously, I'm not suggesting that we will be doing bariatric surgery as a public health intervention to prevent endometrial cancer, but it can serve as a model of risk reduction and allows us to ask the question for the first time, what happens to the endometrium when obese women lose weight? We carried out a prospective cohort study of women with class 2 and class 3 obesity referred for weight loss management at Salford Royal Foundation Trust. Women who had bariatric surgery lost between 10 and 15% of their excess body weight by 2 months after surgery and up to 60% by 12 months. Women who were supported through a low-calorie diet lost some weight at 2 months, but in general this was less weight and more poorly sustained by 12 months. We took endometrial samples and blood at each time point. And this study, which has now been published in the International Journal of Cancer, looked at 80 women, 72 of whom had bariatric surgery, who had a median BMI of 52. And the first thing that it showed was that there was a really high baseline prevalence of occult endometrial cancer and atypical hyperplasia. So we found 4 endometrial cancers and 6 atypical hyperplasias in women who had not approached their GPs or their gynecologist with abnormal bleeding. We found a further endometrial cancer and atypical hyperplasia on final biopsy, and we also diagnosed a stage 1B cervical cancer. Around 50% of our cohort were overdue cervical screening. The women with endometrial cancer were given a hysterectomy. We found mostly low-stage disease, although we did find one woman with advanced cancer who unfortunately needed adjuvant chemotherapy and radiotherapy. But what was particularly interesting was the 6 women with atypical hyperplasia were resampled 6 weeks after they had lost 10 to 15% of their body weight. And we found that their lesions had completely disappeared and they remained in remission. So we checked their endometrium regularly over the next year, 2 years and 3 years, and found that their lesions did not return, suggesting that the weight loss may have had some impact in helping these lesions to regress. Not only did we see morphological change when women lost weight, we also saw a reduction in Ki67, both at 2 months and at 12 months. And these changes were accompanied by profound changes in circulating biomarkers of insulin resistance, reproductive hormones, and inflammation. We saw a reduction in systemic inflammatory markers, CRP and IL-6, but interestingly, we saw an influx of cytotoxic T cells into the endometrium, suggesting that these T cells may be important in immune surveillance in lean women in helping to keep the endometrium healthy by identifying and killing off abnormal cells before they can cause cancer. We saw a change in the molecular markers of the endometrium. You can see in this panel here, before and after weight loss, we saw a reduction in Ki67, but we also saw signs that some of the cancer pathways were either switched on, or the suppressive pathways were switched on, or the active pathways were switched off in response to weight loss. So what does this study tell us? Well, first of all, obviously we found a really high prevalence of occult endometrial abnormalities, begging the question of whether we should be screening these patients for endometrial disease. But perhaps most excitingly, we saw that weight loss was associated with profound changes in the endometrium, not just morphological change, but molecular change that perhaps herald the transition from high risk to low risk endometrium. So moving on to our second intervention, the Mirena coil. We know that the Mirena is effective at treating some atypical hyperplasias and some early stage low-grade cancers. But treatment is really slow. It takes around 12 to 18 months. Recurrence after treatment stops is very common, and we currently have no predictive biomarkers to enable us to say at the outset who is likely to respond. We hypothesized that weight loss achieved during the Mirena treatment window could help to improve outcomes. Not only did we expect to see global improvements in health, for example, a reduction in cardiovascular risk, improvements in mobility, improvements in fertility, and so on, but we also hypothesized that it might actually help improve response to the Mirena coil, that it might reduce the risk of recurrence after treatment has stopped, and if all else failed, it might make the woman a more suitable candidate for hysterectomy. And so we're carrying out the Mirena study. This is for women with atypical hyperplasia or grade 1, stage 1A endometrial cancer who either wish to have fertility-sparing treatment or who are unwilling or unfit for surgery. Those with a BMI greater than 35 are offered bariatric surgery, and then they undergo expedited gastric sleeve or gastric bypass surgery. Those who aren't keen to have bariatric surgery are supported to lose weight through dietary intervention. And this is an example of the kind of responses that we've seen. This is Mary, who has given consent for me to show her picture today. When I first met her, she was 170 kilograms and had a BMI of 60. But a year later, after her gastric sleeve surgery, she had managed to lose 50 kilograms of weight and now had a BMI of 42, and this was accompanied by complete radiological resolution of her stage 1A endometrial cancer and complete pathological response to the Mirena coil. So I think it's really important that we do use the Mirena treatment window period to address risk factors, in other words, to treat obesity. Bariatric surgery may be suitable and may be feasible for selected patients, but even if it isn't, even if women aren't keen to have bariatric surgery, they may be more amenable to losing weight by diet and exercise because they've been given a diagnosis of endometrial cancer. But most excitingly, we're wondering whether weight loss might actually help improve response to the Mirena coil in this cohort of patients. We've also looked at the Mirena coil for endometrial cancer protection. So that is a primary prevention trial asking whether obese women recognize themselves as being at risk of endometrial cancer and whether they will be prepared to engage in risk reduction using a Mirena coil. So again, we took blood and biopsies before and after the intervention, and our primary outcome was to look for a change in Ki67. But equally importantly, we were interested in whether women would be interested in this trial, whether it would be feasible to insert a Mirena coil in the outpatient setting, and whether women would be compliant with the intervention and how long they would keep it. So this study has just been published in Cancer Prevention Research. We asked 104 women to find out if they might be eligible. 54 were eligible and 35 consented to take part. They had an average age of 54 and a median BMI of 47. 25 women eventually received the Mirena. Interestingly, 3 were not eligible because they had occult endometrial abnormalities at baseline. We saw a 15% drop in Ki67 with 6 months of the Mirena coil, and those who were premenopausal, noticed improved menstrual function and quality of life. But what was particularly interesting was that all 25 women kept their Mirena coil for the full 6 months of treatment, and 24 of them chose to keep it after the trial ended for ongoing endometrial protection. So finally, my last intervention, what about metformin? Well, metformin hit the headlines 5 to 10 years ago with headlines such as diabetes pill beats cancer, costs just 2 pence a day, can a dirt cheap diabetes drug fight cancer, and the cancer drugs in your bathroom cabinet. And these were essentially based on 3 lines of evidence. First, that type 2 diabetics taking metformin had a reduced incidence of cancer than type 2 diabetics not taking metformin. Second, that cancer cells grown in the laboratory grew slower when exposed to metformin. And third, that breast cancer patients treated with metformin and chemotherapy were more likely to be cured. And so we were interested in seeing whether there was a signal in endometrial cancer. And so we carried out a pilot study and then a multi-center randomized, double-blind, placebo-controlled trial looking at giving metformin versus placebo during the 2 to 4 week pre-surgical window period between diagnosis and hysterectomy for endometrial cancer. Unfortunately, the signal that we saw in the pilot study was not replicated in the placebo-controlled trial, where both the metformin arm and the placebo arm showed a reduction in Ki67 that we thought was probably due to the surgery itself. Who should we target for prevention? Well, we think women just before they enter the most risky periods, so aged between 45 and 55 years. And in addition to thinking about body mass index, we would like to develop a more sophisticated endometrial cancer risk prediction model that also incorporates other risk factors for the disease, like reproductive factors, insulin resistance, and a genetic score. We know that endometrial cancer is more common in certain families, that there are hereditary predisposition syndromes like Lynch syndrome that increase the risk of endometrial cancer, and also that there are genetic polymorphisms that modulate an individual's risk of developing the disease. These are really difficult studies to do, but I do feel that we mustn't let that put us off, because defining who is at risk of endometrial cancer for targeted prevention and screening, asking how obesity causes endometrial cancer, and finding out whether lifestyle changes, including weight loss, can improve outcomes in endometrial cancer, were all within the top 10 most important unanswered research questions in endometrial cancer, according to patients, carers, and clinicians from our recently completed James Lind Alliance Womb Cancer Priority Setting Partnership. So now is the time for action. Endometrial cancer is increasing in incidence. Understanding the drivers of endometrial cancer may help us design prevention strategies, and we really need to be acting now if we are to prevent the emerging epidemic of endometrial cancer. Thank you for your attention. I'd like to thank Team Womb and all my collaborators and all our funders. Thank you.
Thank you very much, Emma. Gareth, you can quietly probably just hear the applause behind all those muted microphones of our audience. So that was.
I can do some applause you can hear.
Thank you, Gareth. So Shall we spend a moment just looking at some of the questions that have come up? And if Gareth, you've been asked by Nikki, how do you imagine the SNP testing before performed in the future? So do you want to just address that topic?
Yeah, there's quite a few questions there, but in terms of the SNP testing, at the moment with the screening program, the obvious time to do it is at first invite. So when a woman comes for her first mammogram, you look at her mammographic density, you look at her risk factors, and you take a saliva sample for DNA. We now can use up to 313 variants in the test. And as I said, they make a substantial difference to the risks. And they do predict, there's another question from Bruno, they do predict the type of cancer as well. So there are certain SNPs that predict estrogen receptor negative breast cancers, the more risky ones in terms of earlier deaths, and also those that particularly predict estrogen positive. So we can actually do an algorithm that predicts each type as well as a total risk of breast cancer. My feeling is we need to move that earlier because, 20% of women get breast cancer before the age of 50 or a bit less than that now. And screening is possible between 40 and 50 with NICE approval if you fit this category, moderate risk category. And we think we can, again, identify at least 20% of the female population in their mid to late 30s who would benefit from annual screening through until 50. And just to clarify, the SNPs will be far more useful on a population basis than doing BRCA testing because they make a difference to such a huge proportion of women. Do you want me to answer Matt's question as well while I'm on a roll?
Matt's question, Gareth.
So Matt suggested that it's only helpful if the SNPs push your risk category up into a more actionable category. So if you're low risk, it pushes you up to average risk, so you get normal screening. But that assumes that there's no benefit from not being overdiagnosed. So you have the problem that women are overdiagnosed with cancers that are overtreated that would never present clinically. And we will reduce overdiagnosis and the anxiety that women go through, the horrors of a breast cancer diagnosis, when they probably need never have been diagnosed in the first place. So there are benefits in the low risk category as well as obviously in the higher risk categories.
So I think we have to let Emma take a turn then. And Emma, do you want to address some of the questions around?
Yes, I've seen some in there. So I've been asked by Rachel Broadbent whether there was any exploration of the factors motivating women to accept the intervention or the barriers to accepting it. And a very similar question from Lorna McWilliams asking whether there was any evidence to say how aware women are about the link between obesity, endometrial cancer, and whether or not they'd be willing to engage in risk reduction. So actually, yes, we did. We asked 72 women with a BMI greater than 40 whether they were aware that they were at increased risk of endometrial cancer, and just over half were. We then asked what kind of interventions they might be interested in taking part in, whether they'd be prepared to lose weight, to eat healthily, to exercise more, to take a pill every day, or to have a Mirena coil. And interestingly, the proportion of women who were prepared to do these different interventions decreased as the invasiveness of the intervention increased. So only about half were interested in a Mirena, but 94% said they'd be prepared to lose weight, although they recognized that 42% said that they actually thought it'd be quite difficult to sustain. So there was a lot of awareness about barriers, and yet people did seem keen to engage in risk reduction. But not that much awareness about what the risk factors are. And interestingly, they did seem to confuse cervical cancer and endometrial cancer, and we're talking about risk factors like sexual promiscuity and condoms and smear tests. I'll just take another question that I've seen on here as well, if that's all right, which is a question about a side effect of Mirena is increased weight. So how would that fit into what you're trying to avoid in terms of reducing weight, managing insulin level, and reducing estrogen? So actually, we don't find that the Mirena causes weight gain, which is why we're using it. Definitely the systemic progesterone progesterone increases weight. So that is, you know, any of the systemic medications causes weight gain, bloating, systemic side effects, but not so much with the Mirena. And actually what's interesting is as the BMI goes up, systemic absorption of the progesterone in the Mirena goes down. And so you might expect you get even fewer side effects in our at-risk target population.
And Emma, do you want to just comment a little bit about the role of estrogen and insulin that's been raised by, who's done that? That's NUA.
Yeah, so I mean, I think that there is a kind of metabolically unhealthy obesity and metabolically healthy obesity. So I think, you know, for example, physically active women who are obese seem to have reduced risk of endometrial cancer compared to less physically active women who are obese. Certainly in our weight loss study, it was the women who had both obesity and insulin resistance that we found these occult endometrial abnormalities in. So I think that it's definitely a combination of the two, but I think it's the metabolically unhealthy obese that we really need to be identifying and targeting.
Just for my knowledge then, how important is the adiposity to increase aromatization of androgens to estrogens? Is that a part of the mechanism, and does that have therapeutic implications?
Yeah, I mean, that's definitely what we think is going on in postmenopausal women. In premenopausal women, we think that because they're not ovulating regularly, because often they've got PCOS or other reasons, they've got anovulatory cycles, they have continuous exposure to estrogen and not so much exposure to progesterone. So, but we do think in postmenopausal women, it's all about adiposity and aromatization. However, interestingly, the changes we saw with weight loss happened before women lost an appreciable amount of weight. And so we think, you know, it is metabolic surgery that they're having, and it could be reversal of the metabolic insult of obesity that happens first and actually can help restore endometrial health before the women become lean.
Gareth.
If I may, can I come in on obesity and breast cancer? Because,
well, that's the point. What impact is our Emma's intervention going to have on those women's risk of breast cancer, was my question.
Well, it depends, obviously. Well, I'll have to explain that it's a bit more complex in breast cancer. That actually the worst situation is if you're normal weight when you're around 20, and then you put on a lot of weight. So I guess a lot of interventions would, and Michelle Harvey's involved in this, is trying to stop women putting on weight, and typically they do put on a lot of weight around the menopause. Sorry, I shouldn't be saying this as a man, but typically that's often when it happens. So trying to prevent that will not only reduce endometrial risk, but reduce breast cancer risk. There's a strange irony, though, that women who are obese when they're 20 are protected against developing breast cancer even after the menopause. And while that's great from that point of view, unfortunately, those women are far more likely to die of just about everything else, because if they stay obese, they have huge increased risks of cardiovascular death, diabetes, other cancers. And so those women, I'm sure, would also be at increased risk of endometrial cancer. There's something that being obese at a very young age does to protect the breast against, they have lower breast density, for instance, which seems to help protect them. But women who are normal weight or underweight at 20 and obese when they reach 50 double their risk of getting breast cancer after the menopause. That's a massive increase. You'd have to drink 20 units of alcohol to get that high.
Per week or day, or like so?
Well, no, I think to be fair, 15 units of alcohol a day would get you a doubling of breast cancer risk.
Oh, good. So, Ben, we're just gradually approaching time to wrap up, in a sense. And the question I'd like you both to think of, just quickly to give us a number, is how many lives do you save? How much do you, the interventions that you're talking about, you've talked about risk factors, but actually, is it possible to actually put that down into number of women whose life is being prolonged, who are being saved? And the second final comment is really around this theme of obesity, because had we done this 15 years ago, the biggest cause of cancers would be smoking related. And that potentially, and then we're going into an era where smoking is becoming less common, and by implication, obesity may be the single biggest preventable risk factor. Do you want to briefly address that?
Yeah, I mean, I'll just start by saying that we have about 9,000 endometrial cancers every year in the UK. And so if we think about 35% of those are directly due to obesity, then around, maybe we could save around 3,000 lives if we could really work on this obesity challenge with regards to endometrial cancer risk.
So in terms of the risk stratification, if we were to do that, and all women who were eligible were to take anastrozole, you would prevent around 1,800 breast cancers a year, and you would be able to downstage 45% of breast cancers by more accurate, you'd prevent 1,800 breast cancer deaths a year in terms of the proportion of breast cancers, and you'd be able to downstage 45% of breast cancers, and therefore you'd add in an extra group that so out of the 11,000 odd breast cancer deaths a year, by a combination of extra screening in the high moderate risk and using anastrozole, you would probably be getting at about 2,500 of those deaths would be prevented. So a very, very significant, but that's assuming complete use and complete uptake of anastrozole, which is a big ask.
But it's important to understand the actual large numbers we're talking about here.
Yeah.
Yes. And your other question, is obesity the new smoking? Absolutely. I definitely think it is.
Gareth, do you have a final comment to add then, as we're over time and we're going to wrap up now?
No, I agree. It's a hugely important area, and we need to be able to actually assess obesity as to its effects on various cancers, including endometrial and breast, and be able to show women in risk models how much they can reduce those risks by putting their weight back into a normal range, or not gaining it in the first place, which is probably the best thing, and sticking to a healthy weight and a good lifestyle.
Both, and I thank you both greatly. I'm sure the audience appreciate it. I'm sure there will be people watching this on YouTube in the days and weeks to come. I'm extremely grateful to the pair of you. I encourage the audience to sign up for the next MAHSC seminar in 2 weeks' time on BAME and the relationship to COVID-related morbidity and mortality. Thank you all very much. Thank you.
Thank you.
Cheers. Thank you.
Thanks. Bye.